I am George Udvarhelyi, Professor Emeritus of Neurosurgery at the Johns Hopkins Medical Institution. It's a great pleasure to be here this morning and interview Dr. Earl Walker, who has been at Hopkins for 25 years, and I had the privilege to work with him between 1955 and 1973 when he retired. Before we are going into the neurosurgical aspects of his career and asking a few questions, I would like to ask Dr. Walker if he could elaborate a little bit on his early background with his family and his early exposure in his educational process back in Canada.
Thank you, Dr. Udvarhelyi. Well, I was born in Winnipeg, Canada, in what is now the center of the city there. As I recall, it was 52 Main Street. And we lived there for a very short period of time, probably 6 months or so, and my folks migrated to Western Canada, to near Edmonton. We had a homestead out there. My mother took care of things. I have a photograph of her, which I might show you.
Yes.
We always thought she was quite beautiful. And we lived there for 2 or 3 years and then moved into Edmonton, at which time it was the capital of Alberta, but only a city of about 30,000. And we were there for most of my academic life. My father, who's in this picture, was a construction engineer, and his job was to build grain elevators, so that practically all of the smaller towns around Alberta, which at that time was a grain-growing country, were built by him, by the United Grain Growers. That kept us busy in the summertime. In the winter, the season was sufficiently bad that you couldn't do any outside work. But as soon as the weather was fair, why, we'd go back on the road and build these grain elevators. Now, this continued until we went to school, and I was fortunate at that time to go to the most modern school in Canada. This was a school, a photograph of which I have here, this King Edward School. It doesn't look very modern at the present time, but back in 1911, 12, 13, it was quite modern. We lived only a few blocks from this, so that we could walk over every morning. And matter of fact, I enjoyed walking across there. Well, I continued on and went to the university, got my education there, but in the last couple of years, I had a very interesting experience. The Provincial Mental Institute, which was a branch of the main provincial mental hospital at Ponoka, had a small colony outside of Edmonton at Oliver. And in this colony, they sent the cases that were more chronic. Ponoka got all the acute cases, and they were taken care of at Oliver. They wanted an assistant out there to help the superintendent. As a matter of fact, the superintendent was not too interested in psychiatry, so that I took on the job of his assistant, and for practical purposes ran the hospital. We had at that time approximately 350 mental patients out there, of all types. Very, very interesting. A few epileptics who would have seizures every few weeks. The attendants got to know when they were going to have the seizure, because these people would get a bit agitated. It'd be more difficult to manage. And then they would say, well, now, Jack is going to have a seizure. And then he'd quiet down and be quite peaceful again. We had other patients there who were quite maniacal. At times, very maniacal. I recall one patient who about every 4 or 5 months would have a manic phase. And on one occasion, as I came into the ward, the attendant said, this chap is very bad today, Braddock, you better look out for him. So I went in. I usually was able to talk to these people and to calm them down.
Mm-hmm.
But occasionally, that wasn't the case. And as I entered the room, this chap looked at me, and he picked up a towel, and came after me, and he said, "You're trying to kill the King of England." And I tore out the door and out around the day room and back again, and the attendant ran ahead of me. I think the attendant was more afraid of Braddock than I was, and he tried to slam the door shut, but he was slamming it in my face. Eventually, we got Braddock back and had half a dozen attendants come and put him in a hot bath and calmed him down.
Mm-hmm.
But we had to rely entirely in those days upon attendants. If anything went wrong, we would get a number of attendants so that there'd be no possibility of being overwhelmed by a patient. On another occasion, I was called because they said that one of the patients had escaped. Not really outside, but he had escaped into an area between the window and the ward, a window that was barricaded with a wire cage. And he had poked his hand through the window and was rubbing it around. He had blood all over. He'd cut some vessels and a number of scars over the arm. And it was a problem to get this chap out between the screen and the window. So I, after I saw the situation, said, well, you just keep him there a moment. And I went back and got a bottle of chloroform and a towel and poured the chloroform over the towel and put it over the chap's head. And when he went out, we lifted him out in toto, put him out the floor, and then we were able to take care of him. I spent the rest of the day sewing up all his wounds of the arm.
Well, I assume that was your first exposure then to some aspects of neurology.
I beg your pardon?
That was your first exposure to some aspects of neurology, epilepsy, and some of the areas then you later on got involved.
Well, that's very true. I had a very interesting exposure at that time because there were these 350 patients there, and in the summertime, I had about 4 or 5 months that I could spend out there with them. And then in the winter, I would go to the university for the medical school classes, as everybody else. Have to get up at 6 o'clock in the morning and drive into the school. And then I'd come back after the classes at 5 o'clock and take care of the patients.
Mm-hmm.
So that I had an opportunity to see all of these patients, see a lot of psychiatry,
Mm-hmm.
but also a lot of neurology.
Mm-hmm.
I made it a point, just for my own interest, to examine all of the patients that were there over a period of time. And thus I got to be able to use an ophthalmoscope and to see something of the fundi and do a neurological examination and get some idea of just what neurology and psychiatry was.
Well, I must say then, those of us who work with you understands a little bit better the discipline you had during your stay here at Hopkins. When I came to Hopkins in 1955, when you kindly offered me a fellowship, and I came from Edinburgh, I was interested in your program because it emphasized the different phases in neurosurgical training, namely the clinical research, practice of surgery, and of course teaching, as most of the programs centered about the diagnosis and operative treatment of neurological disorders, and especially that was the case in Edinburgh, which was very patient-oriented and clinically oriented, wonderful training, but there was no emphasis on scientific research and to open the perspectives to the different areas in neurology in a broader sense. So why were you emphasizing the other aspects of neurosurgical training? It would be nice to hear.
There were several factors that were involved in this. In the first place, when you came into training, it was a period when we had quite a number of trainees in the field, not only at Hopkins but in other parts of the country, because it was just after World War II. And in World War II, a great number of people were assigned to the neurology and neurosurgical services and came to like the specialty. So they wanted training. And throughout the country, probably 1,000 or more people wanted training in neurosurgery. And it looked to me as if we were just training clinical neurosurgeons, we'd have an overabundance of neurosurgeons, but not too many academic or investigators. And so that at Hopkins, we had the opportunity to do investigation. And thus, I made it a point that people who were coming into the training program should be trained in investigation. It might be in any one of half a dozen fields. We had in the department people who were expert in electroencephalography. We had other people who were interested in various other aspects of investigation. And for that reason, I insisted that everyone coming into the program would have exposure to some type of an investigative study. Now, I realized, and it's well known, that even though they had this exposure, that the majority would probably not go into investigation or stay in academic work. And in general, it's worked out about 1 in 3 of our trainees actually continued investigative work and were in most cases with an academic faculty after their period of training.
Well, at least we all have been exposed to it. We know what it's about, and it was very important for us when we came here, talking to myself and some of the other colleagues who worked at that time. It was a sort of international crowd, if you remember, when we started to work on experimental epilepsy. I remember we had fellows from Peru, the fellows from France, from Italy, and it was a very exciting time to be able to participate in a different way in neurosurgical research.
Well, that's very true. I think that the training that the younger people had in investigation was a real value to them, even though they decided later on that it was too hard and they wanted to do clinical work. It's much better to have the plaudits of the patient than those of the monkeys.
That's right. Well, let me ask another question. When I came to Johns Hopkins, of course, I knew about some of the great characters, the founders of Johns Hopkins, Dr. Halstead, Dr. Walsh, Dr. Osler, and Dr. Kelly, the 4 people who are really have been the basically responsible for the type of approach of teaching medicine and practice medicine in this institution. What is your thinking about the fact that are at the present time similar giants, such giants present? Do you think that a similar type of development will occur in modern medicine?
Yes. These men, 60, 70 years ago, stood out because there were relatively few people in these individual fields. And consequently, they were much more obvious. Today, we have 10 times more people in each of these fields and in other fields, so that even though there are giants, there are so many of them that they don't stand out the way they did.
That's right.
And when I first came here, we had a great number of people who were outstanding in the field. Dr. Rich in pathology, Phil Bard in physiology, Frank Walsh in ophthalmology. They were really superb, and I could name half a dozen more, Mac Harvey in medicine, for example. So that they perhaps didn't stand out quite the way they did in the early part of this century, but they were still giants.
Well, apropos talking about giants, I would like you to talk a little bit more about two of them with whom we had so much contact at that time, namely Frank Ford, the neurologist, and Frank Walsh, whom we call the father of neuro-ophthalmology. And we all recall this wonderful Saturday morning clinical discussions when all sorts of people from the different disciplines came and in a very relaxed way discussed clinical material with input from the various specialties. And that is a very important memory for all of us. Perhaps you could say a few words about these personalities like Frank Ford and Frank Walsh, with whom have you been associated?
Well, you're quite right. People who went into neurology were always looked upon as perhaps a little queer. They weren't quite psychiatrists, but they weren't quite physicians. So that these people who were in neurology and the neurological sciences often had outstanding personalities. Frank Ford was no exception. He was a bald-headed chap who walked around very quietly. When asked to see a patient, he would put the name down in his little book, and sometime later on would wander into the ward, take the chart, read it through, scribble a few notes, and then go and see the patient. Make it what I thought was a rather cursory neurological examination, take out his piece of paper and write a few more notes, and then leave. And the next day, in most cases, you would get a letter typed up by him with the detailed history of the individual, the neurological findings, and a brilliant diagnosis. Now, once in a while, you didn't get it the next day. It might be 3 or 4 days before you'd get it. And you knew that in that case, this was a bit more puzzling case. And he'd have to look up a few things before he gave an opinion. But he was really an amazing clinician and a tremendous help to neurosurgeons at the hospital.
Yes, I remember that the Saturday morning meetings, after 40 years being together there, still it was Dr. Walsh and Dr. Ford, and when Dr. Ford became a little bit less understandable in his later years, Dr. Walsh always translated what Dr. Ford wanted to say, and they are discussing and reminiscing of cases 20, 30 years ago and connecting their clinical observations, which was really a very, very pleasant experience for us.
Now, the other personality that you mentioned was entirely different. Frank Walsh was a tall Canadian who came over here from Western Canada in the 20s and had been here practically the remainder of his life. He was not trained in neurology, but was a general practitioner. But he was interested in the eye and ophthalmology, and particularly the ophthalmology of the nervous system. And so he was really the founder of neuro-ophthalmology. He was a very outgoing individual, so that if you came to his clinics, he would greet you very heartily, shake hands, delighted to have you, and would probably ask you to discuss one or two of the patients that he had. These were Saturday morning clinics to which all of the ophthalmologists were present, and many of the interns from the hospital. Saturday being a relatively lax day, it was possible to get away from the awards on that day. He was really an outstanding individual. As I say, he had not had formal training and consequently was not a great neuro-ophthalmologist from the standpoint of anatomy or physiology. But his practical experience was really tremendous. He had seen practically everything that there was to be seen, because being the only person who was interested in the neurology of the eye, every patient that came to Hopkins with anything suggesting a disorder of the visual system would go to Dr. Walsh. And if he wasn't quite sure what it was, the patient would be at his Saturday morning conference, and there'd be a discussion of the case. And he'd have the opinions of Dr. Ford, who sat in the front row, Dr. Chambers, usually there as well, some of the internists, and other people. Even we dropped in occasionally, if you recall.
Yes, that's right.
So that he was able to get opinions from highly specialized individuals on all of his cases. And he really had a remarkable service.
Well, to go into another aspects of here, in the early years of neurosurgical specialty, it was quite dependent upon and subservient to surgery and neurology. And I would like to ask you if you could elaborate a little bit what was the effect of such an alliance, because I remember when I came and the subsequent years, we always admired you that you really sort of embodied all the disciplines which in those days was related to the basic question how the brain works. So we have learned from you and participated in neuropathology. We learned from you and participated in basic neurophysiological concepts. You were able to read and illuminate us about EEG. So you, and of course, a wonderful concept of neurology itself. But I think that was not always the case. So would you elaborate a little bit how you see this development from the dependent situation of the disciplines from surgery and neurology to the independence which later on developed?
Well, that has been an interesting evolution. In the days of Harvey Cushing, back in the 20s, very early 30s, neurosurgery was the specialty relative to the nervous system. Neurology was an infant, practically just out of the cradle, as a matter of fact, in most parts of the country, although in England it was a bit better developed. But neurosurgery in America was the master in nervous disease. And consequently, a person going into neurosurgery had to know everything about neurology as well as about neurosurgery, because he had to make his own diagnoses. He had to rely upon those for operation. It isn't as it is today, where he has a neuro-ophthalmologist who takes the patient, runs them through a number of specialized studies, and makes the diagnosis for the neurosurgeon, who then can operate. But in those days, the radiologist could only tell that there were some bones in the head that might be eroded here or there, but in most cases was not able to make any kind of a diagnosis, nor was he interested in neuroradiology. When I first came here, the X-ray department had no interest in neuroradiology. We had to do our own myelograms, our own angiograms, and all other special examinations which required X-ray control. And it wasn't until later that these other specialties developed. This has made a tremendous difference in the field of neurosurgery. We now have people in neurology who are interested in some of the surgical aspects of neurology. We have specialists in the field of endocrinology who are interested in the brain, particularly pituitary. And they are a tremendous help in the diagnosis and the treatment of cases. So that neurosurgery is now quite different than it was back 50 years ago.
Well, do you think that we are losing something of the panoramic view which we had in those days when we had to be involved and participating? As you said, for example, in neuroradiology, I remember when I came, indeed, just being exposed a little bit to neuroradiology in Europe, where I came from, you know, having half one eye, you are king in the land of the blind, as used to say. So we were able to carry that on and work on it till, as you pointed out, it became an independent discipline. On the other hand, with the loss of this panoramic view and super specialization, do you think that we are looking forward to a better product in neurosurgery?
No, I don't think that we are losing a great deal. As a matter of fact, we gain much more than we lose, because back in the 30s, we had to rely upon our own ignorance to make the diagnosis of neurological disease. Now, we have probably 3 or 4 specialists see every case before the neurosurgeon makes the diagnosis. And those 3 or 4 individuals each have highly specialized technical procedures that help them in making the diagnosis. Consequently, when the neurosurgeon gets a case now, the diagnosis is probably made, the surgical state of the individual is well known, and the patient is in much better condition to undergo a major procedure.
Well, that is probably true. Now, another question is about the meetings. In Europe, in America, the surgical meetings were dominated in the early days by the general surgeons. Could you elaborate a little bit, what do you think, what were the factors leading to a declaration of independence by these specialties, which is along the same line we already talked a little bit, but indeed it was quite amazing how the independence of the neurosurgical societies developed, and you have been very much instrumental in that. Perhaps you could say a few words about it.
Well, of course you have to realize that 100 years ago, neurosurgery, or what neurosurgery was done by general surgeons, and usually by the professor of surgery in the major universities of Europe and in this country. And the reason was that the mortality from any operation on the brain was tremendous. It was 70–80%.
No.
And consequently, lesser lights in the field of surgery would not tackle a neurosurgical procedure. And so in Germany you had Krause who would do something. In England you might have Horsley or 1 or 2 others, Balance, who would operate. And over in this country, Cushing began to operate. Mm-hmm. And in Germany, the situation was so bad that the neurologists decided, well, I might as well operate because if I send him to the surgeon, the patient's going to die. But if I learn how to operate, I can get some benefit from it, and at the same time I might be able to get a better result than the surgeon. And so Förster took up the scalpel. Right. And Clovy Vincent did the same in Paris. Correct. So this was the situation 75 years ago. Well, things have changed since then. As I indicated a moment or 2 ago, the diagnostic procedures are much better. The surgical techniques have greatly improved. Anesthesiology, which was a bugbear for the early neurosurgeons, and as a matter of fact, many of them would not have anesthesia given to their patients because they said the anesthetic was more deadly than their operation. and they would do their operations under local anesthesia. Cushing did most of his operations that way. It wasn't until about the 1920s that intratracheal anesthesia was used. So that these developments have changed the picture of neurosurgery tremendously.
Well, these local and international neurosurgical meetings, after they developed in an independent way, what kind of effect you think had on the medical community in general?
Neurosurgery in the 30s, I would say, came of age. That was the time that Cushing had shown it was possible to operate upon the brain with a permissible mortality. When the 8 out of 10 patients died after a brain operation, no patient would voluntarily enter a hospital for a brain operation. But after Cushing demonstrated it was possible to operate on these patients with a mortality that was under 10%, people began to realize that developments had been made. And that led to a different philosophy entirely of neurosurgery than had been prevalent prior to that time. I can remember, for example, when I was at medical school, we had a surgeon who did operations on the brain. But he had great difficulty. And as a matter of fact, the only operation that I saw of neurosurgical interest was a laminectomy, and that patient died on the table. Died from blood loss. And as you probably recall, back in those days, why the residents would plan their evenings depending upon what had been done during the day. If a neurosurgeon had operated during the day, why, he'd have to stay in the hospital that evening.
Right. Well, that was, of course, much more demanding job in those days, although techniques have been developed very much in the last 2 decades. Still, the attendance and almost permanently be a resident, the word resident was used for that reason in this hospital. We had to be there, and some of you were pretty strong and strict with us when we started to work for you. And that brings me another questions which I would like to ask you, because you talked about the development of this independence of the discipline, the impact of neurosurgery in general in the medical community. But you have been really responsible from the very early stage of the international recognition of neurosurgery, and was instrumental in the organizational committee of the World Congress of Neurosurgery and the cooperation and coordination of the various societies all around the world. Could you talk a little bit about your missionary spirit to carry the torch and indeed being instrumental to bring this crazy specialty together and create a common denominator?
Well, neurosurgery back in the 20s and 30s was practiced in some countries of Europe and in the United States of America. But in the other countries of the world, except for an occasional general surgeon who might do some neurosurgical procedure, there was no neurosurgeon. And in the 30s, the neurosurgeons, as I mentioned previously, were more or less under the domination of the neurologists. They were the handmaidens of the neurologist, and they would operate upon the case when the neurologist found the patient was practically blind, and dehydrated, in very bad shape, and he could no longer take the cathartics that were being administered. He was sent to the neurosurgeon to operate, and consequently the results were bad. But things changed. They changed very drastically. just after that period of time.
Yeah, I remember the Sir Geoffrey Jefferson telling this story when he left London, the Queen's Square, for the same reason, to get an independent position in Manchester, and just showing that neurosurgeons can carry the show and they are not just slaves, so to say, of the very outstanding neurological group in Queen's Square in those days. So he commented on that. I remember Professor Dott making the same statement, that how difficult it was in England, for example, or in Britain, to establish that.
Well,
but
you see, in those days, when the neurosurgeon, as you put it, was the slave of the neurologist, the neurosurgeons went along with the neurologists. They attended the neurological congresses and so forth. But when they began to get a little more independent, Cushing did not rely upon a neurologist to tell him where to operate. He made his own diagnosis, and he operated when and where he wanted. And that was beginning to be the case throughout the world. And there were, perhaps 100 neurosurgeons around the world in the 1930s. And some of these began to feel quite independent. They no longer wanted to be part of a neurological congress, but they wanted their own congress. And so in 1939, there was the suggestion that there ought to be a neurosurgical congress. At that time, the war broke out, and nothing could be done for another 8 years. But when the congresses were resumed in the 1940s, the thought was again broached. And Dr. Scoville from Hartford, at the suggestion of some of the European neurosurgeons who did not want to have the neurologists in their clinics know that they had suggested it, sent out a letter suggesting that there be a congress of neurosurgeons.
that was in Brussels, the first congress we are talking, the 57. Yeah, but what about the next, the second and the next congress?
But even prior to that, there was the suggestion. And Dr. Senko, for example, tried to get the neurosurgeons interested in having a congress. And as a matter of fact, started congresses in South America very early, before congresses of neurosurgeons were being held in other parts of the world. But in Brussels, the first recognition of the neurosurgeons as a separate group was made. This was rather an interesting occasion. The organizing committee for the Brussels Congress met in Brussels, and just before that, a day before, about 20 neurosurgeons had been invited to come to a meeting in Brussels to discuss the formation of a neurosurgical congress or some type of neurosurgical organization which would hold congresses. And people from many parts of the world, Europe, not Asia at that time, but America, met there. I think there were about 20 neurosurgeons at that meeting. And they decided that they should have their own congress. Geoffrey Jefferson was selected as spokesman. And so the next morning, when the neurologists met to formulate their plans for the Congress, and Geoffrey Jefferson, as well as some other people who were representatives to the neurologists, presented to the chairman, Ludo von Bogart, the ultimatum that the neurosurgeons wanted their own Congress.
Great.
They admitted that since the next Congress was going to be held in 2 years, they probably would not be able to have time to formulate their plans in that period. But They wanted to have their own sessions. They wanted their own chairman, their own leaders. And Van Bogert saw the handwriting on the wall, and he said that would be all right. Even Francis Walsh, who really didn't have much use for neurosurgeons, begged that the neurosurgeons not leave the neurologists. And as I recall, he said, we're at the crossroads. We need your help. But the other spirits went along with the neurologists. And so in Brussels, the Congress was made up of 5 separate units, all meeting together under the same roof: the electroencephalographers, the neurologists, the neuropathologists, and the neurosurgeons. We had different colors on our badges. I think appropriately the neurosurgeons were red. But this was the first meeting formally of the neurosurgeons.
And then came the Washington meeting, I think, in 61.
Subsequently,
right?
Congresses have been held for neurosurgery every 4 years. The second one was held in Washington under the presidency of Paul Bucy, and was exceptionally well received.
And then you had one in New York City then later on.
Yes, they met in New York City.
And you have been the resident at that time.
It was probably the first time that many of the Europeans had an opportunity to come to America. This was, I think, true also of the Japanese, so that there was a very considerable interest in this Congress of neurosurgeons from countries that otherwise had not been represented. We had a number, for example, from Russia. The USSR, although they'd been invited to come to our organizational meetings previously, had not done so. But there were 4 or 5 at the Washington Congress. And since that, there have been more and more. And as a matter of fact, the next European Congress of Neurosurgeons is being held in Moscow.
In Moscow, yes. We are looking forward to that. Well, as you have been one of the founder and really the proponent of this whole idea, how you see the future? How you envisage the future of such congresses?
Well, the Federation of Neurosurgical Societies has grown tremendously. As I mentioned, it started off with only a few hundred. And now there are at the congresses somewhere between 3,500 and 4,000 people. So that the congresses are being so large that there is serious discussion of having subdivisions of the Congress which will meet in different places. For example, the neurotraumatology group have their meetings at other times than the Congress, simply because there just isn't time in a general Congress to get together and discuss things. Moreover, when you have 4,000 or 5,000 people at a Congress, there isn't the opportunity to sit down and talk to somebody that is knowledgeable in the field. Back in the 50s, when we had a Congress of neurosurgeons, you would know all of the neurosurgeons there. You'd be able to sit down over a glass of beer and discuss things that were going on. But now that is not possible. So it looks as if there will have to be some type of parcellation of the neurosurgeons, maybe the pediatric neurosurgeons or the stereotactic neurosurgeons or tumor neurosurgeons will have their own Congress, or at least meetings, and then come together with the remainder of the neurosurgeons. This perhaps is not quite so important in some of the developing countries, where neurosurgery is still rather in its infancy. But in places like Europe and USA, even in South America, there are so many neurosurgeons that are now highly specialized that some such division of the group will be made in order to put across the ideas. Unfortunately, at the present time, at the congresses, some of the developing countries do not have an opportunity to present their papers. Take, for example, the South American countries, Argentina, Peru, and some of the other countries at the last Congress had maybe 1 or 2 papers on the program. Well, this is not desirable. It would be much better if these developing countries would have an opportunity to present their work and to get the advice of the neurosurgeons in other parts of the world.
Well, let me ask you some two perhaps more personal questions before we end this interview. One is related, in my experience, to the fact that when we organized your 60th birthday party here at Hopkins, I was so impressed by the extraordinary enthusiasm and dedication of all people from all around the world to come here for a 3-day symposium and pay tribute to you and your far-sighted vision to bring them together. On a personal level, as you perhaps know, when I left different European countries where I was originally trained, I spent a few years in Buenos Aires. I never forget when you came over to Buenos Aires in 1949, I think it was, and the impact you made already at that time for the South American countries and trying to mobilize them and involve them in the revolution of neurosurgery. And you have maintained this attitude. Can you say a few words just what you had at that time ticking in you to do that? Because that was utterly unusual. As I was in charge to organizing this meeting for your birthday, I was impressed that people volunteered to come on their own expense. We didn't provide to these people, wanted to be here, want to talk about their scientific work and about all the benefits they got from you and from the far-sightedness to bring them together. I think for us that was a very impressive tribute to you, and perhaps you can say a few words. What was the motivation of yours, how you managed to do that, because it was quite an achievement.
Well, I felt very honored and grateful to all the people who came to that birthday party. I had enjoyed a great deal the opportunity of working with people from other countries. It seemed to me that in the United States that we had developed a specialty that was viable and that was essential to the health of the nation. Whereas in many other parts of the world, there was no neurosurgery. And that it was necessary for us here to go into these other parts and preach the gospel of neurosurgery by training people from their own country so that they could go back and do neurosurgery there. And there have been a number of neurosurgeons in this country who felt the same way. And they have made a point of having 1 or 2 people on their service from, you might say, the developing countries of the world who would go back and carry on the specialty.
Mm-hmm. Well, another personal question perhaps is related to the way we felt, at least, you have been involved in teaching by personal example. I must say that it was not easy to work for you because you requested real dedication, discipline, and dedication and objectivity. And I think if you could tell us a little bit how you reached this type of teaching, which was difficult for some people, but it was very beneficial for those who really realized what it means. We used to make the joke, if you remember, in those days when we worked for you, that you would be the happiest man if you get them early morning, as you did, and we started at 5 o'clock in the morning to do some of the experimental evaluation, as you remember, and then you go and you read the EEGs, then you go to the operating room and do the operations, you come back and you review the pathology, all well disciplined, and then clear the laboratory completely, and then go home after a good day's work. Well, but there's a difficult sample to follow, but I would be interested to hear how you developed this type of attitude, which made enormous impact on those of us who had the privilege to work with you.
Well, Dr. Udvarhelyi, you must realize that back in the early part of this century, the neurosurgeons and the people who were operating upon the nervous system were rather rugged individualists. They knew that they were going to have a high mortality. They knew that their results were probably not as good as the general surgeon who was taking out an appendix or an ovarian tumor or something of that nature. And for many years, the neurosurgeons were not particularly respected, and the specialty was not one that was attracted the students. And so that there was the challenge for all neurosurgeons to make their specialty one which would not only benefit the patient to a much greater extent than it had been, but also attract younger people who would develop new techniques, new ways of treating neurological disease. For example, up until the middle of the 30s, people who had sciatica would limp around with a cane, and after 6 months or a year or two would get over their pain and be all right. But at that time, neurosurgeons found that the sciatic nerve was being involved at the foramen, and that removal of a protruded disc would relieve that sciatica, so that these people would be relieved immediately without any neurological deficit. And that is the type of thing that stimulate the specialty of neurosurgery. For example, this particular operation made it desirable for many people to go into the field, because there are a tremendous number of people who have protruded discs and sciatica and low back pain and so forth, which can be treated. And the same thing occurred with other tumors, other afflictions of the body. For example, trigeminal neuralgia. The operations for that have changed, so that before we had to cut the nerve, leave a numb face. Then it was found that various procedures, decompression of the fifth nerve and so forth, would relieve it. These are all advances that have made neurosurgery much more desirable, and have made the general population realize that a neurosurgeon can help a great deal, and they no longer look upon being referred to a neurosurgeon as a sentence of death.
Well, Dr. Walker, although you officially have retired a few years ago, we know that you haven't retired at all. Would you like to just comment in the remaining few minutes what your plans are in the future? We know that you are still working hard, you are continuing teaching. We are just now off to a congress in Africa when we finish this talk here. How are you looking forward, and how do you think that your very beneficial influence will remain with us?
I suppose that I'll continue to be interested in neurosurgery for the rest of my days, and still go to a Wednesday morning conference and listen to the new advances that have been made, I was at a conference just 2 days ago. The neuroradiologists have made tremendous strides in neurosurgery. And now will tell us not only where the lesion is, but what it is, so that operating upon the nervous system is much easier than it was years ago. And the other specialties have helped a great deal. Anesthesiology has made it possible to operate upon these patients with a permissible mortality and with few respiratory difficulties. So I think that there's a great deal yet to be done, and I know I'm going to be interested in seeing just exactly what is being accomplished in the field.
Well,
thank you very much for...
Well, we really hope that you will stay with us, because it was a privilege to work for you, and especially the whole concept is continuous curiosity. I remember, apropos the neuroradiological advances, that you predicted at the meeting in London when the first CAT scan was shown, if you remember that, by Dr. Ambrose, and he's saying, well, that will come. It took some time till we get going on it, which was after your time, but I remember very well how you prophesied the importance of that and how it will change, as it did, as you pointed out, the practice of neurosurgery. So I think we are very grateful to you for all your guidance, all your help, all your visionary attitude in neurosurgery, and wish you good luck for this trip and many other adventures you will have still in your life, and looking forward to be continuing in contact with you. Thank you very much indeed.
Thank you.